Time has arrived for our meeting to begin. We will be meeting today and hearing a presentation by the department on the 08 budget request. By way of housekeeping, we had a public hearing scheduled for tomorrow from 2 to 4, and that has been canceled because of Congressman Norwood's funeral, and we will reschedule that at a future time. If you would, again, put your cell phones on silent or vibrate would be appreciated. Members, you know how this works. If you have a question, and by the way, if you have a question at any time during the presentation, we don't have to wait until the presentation is over. You will press your button on your light, in front of you, and I will be glad to recognize you for a question. Commissioner, you may proceed.
Good afternoon, Mr. Chairman and members of the committee. We have today for you a presentation on the 2008 Governor's Recommended Budget. I'd like to do as we did last time and provide a brief highlight for you, and then I'm going to ask our Chief Financial Officer to fill in all the gaps and go into the budget in much more detail. And then I understood that there was also a request for additional information about citizenship verification with children in the Medicaid program. So we have additional information for you. At your seats should actually already be some handouts on that particular topic regarding the federal rule changes and law that are in place. Okay, I'd like to start by mentioning for the Medicaid program itself, there are about 4 major things that I would like to point out to you before we begin the in-depth budget presentation. Number 1 is the projected growth and benefit expenditures for the amount total of $128 million. However, only $59 million appear in the 2008 budget recommendation. The earlier portion of that, if you will recall, was in the 2007 amended budget as that pre-fund issue. The second is the nursing home provider fee and rate increase for a total amount in state dollars, I believe, of $700,000. Oops, I'm sorry. That's the source provider rate increase, which is a total in state funds of $700,000. Okay, and in addition, we have also some initiatives to present for a funding request in program integrity for fraud prevention and overpayment detection. I'd like to point out that there are several members of the department present in the audience, as well as the division chiefs, who are available to answer any particular questions about some of the initiatives that we'll be rolling out today. Number 2, with respect to the state health benefit plan, we have a projected new state fund need of $215 million for fiscal year 2008. The employer share of that is recommended for a payment of $176 million in the governor's budget. The health plan membership rate increase in their premium is 10%, which would keep it in line with 24% of the premium cost being paid for by the members of state health benefit plan, and this would go into effect January 2008. And in addition, there is a recommendation for funding of the OPEB, other post-employment benefit liability funding for 2008 for state employees, and that recommended amount is $100 million. In addition, with respect to health improvement and access programs, 2 additional initiatives that are in the governor's budget include the health information technology and transparency effort. His recommendation is for $1 million to fund both the pilots as well as the transparency website. And in addition, there is a rural health access program, and funding for that initiative is recommended at $1.5 million. I'll let carry it from here.
Thank you, Dr. Meadows. Good afternoon, Mr. Chairman and members of the committee. If I can direct your attention to the screen, or you should also have this in front of you in the form of a handout. The agenda order that I'd like to discuss the detailed budget items for fiscal year 2008 is as follows. I'd like to just talk briefly about recommendations in the governor's fiscal year 07 budget that are being annualized, briefly touch on the statewide budget changes that are impacting all agencies, not just the department. Talk briefly about the Medicaid and for the Medicaid and Peach Care for Kids programs, the growth in Medicaid benefits that the Commissioner referred to earlier, an administrative transfer related to Georgia Healthy Families between Medicaid and Peach Care, and the program, more detail about the program enhancements in the Medicaid program. For the State Health Benefit Plan, just want to talk very briefly of what's the fiscal status and how that is driving the needs for fiscal year 2008, as well as talk about other post-employment benefits, or OPEB, and then getting into the new initiatives in the Health Care Access and Improvement Program, and also pointing out for you some reductions the governor has taken in one-time funds that were appropriated in 07 that would be deleted from our budget in 08. Then just a brief reminder about the suggested programmatic changes in the governor's budget recommendation for fiscal year 08, and then wrapping it up with just a budget summary of by fund source and where the changes are. For the 07 recommendations that are being annualized, as a reminder, there is funding in the budget for the Health Improvement Advisory Board. This is support. I think you can find it on page 4 of the tracking document, item number 17.0.6. This was something started in the fiscal 07 budget and basically provides administrative support for that Health Improvement Advisory Board, which you might be familiar with, as they provide guidance for the Office of Minority Health, the Office of Women's Health, and the Office of Men's Health. The next item relates to administrative support. I think we went over this in quite a bit of detail when we testified on the fiscal 07 recommendation, and that is related to several new full-time equivalent positions in the department, 8 for contract management, 2 for legal counsel, 2 for the State Health Benefit Plan auditing function, and then 3 for member eligibility. And those are scattered throughout your document as referenced on the handout. And then finally, the Commissioner talked about the nursing home provider fee. That is being increased effective for February 11th, dates of service and later. And that would continue on into fiscal year 08. The dollars that are being generated from that increase in the fee, and again, this is a fee that the nursing homes are paying to the state, those dollars are reinvested back into the Medicaid program and serve as a state matching fund source for a rate increase. The statewide budget changes you're familiar with. I just wanted to give you an idea of what this means for DCH. But just as a reminder, there's an annualizer for the fiscal year 07 salary adjustment that was effective in January of 07. There's also recommended increases for GBA real estate rent, workers' compensation premiums, and as well as an increase in the employer's share of State Health Benefit Plan revenue contributions. And finally, a 3% salary and performance increase effective for January 2008 for those state employees who work for the department and are qualified for such increases, although those add up to about $1.5 million for the department. Okay, jumping into the Medicaid program. This is related to growth in the Medicaid benefits expenditure item. We expect incurred expense to be about 5.8% greater in fiscal 08 as compared to fiscal 07. This is in line with, I'm happy to report, state revenue growth. So I think the charge that we received from the governor several years ago to try to get Medicaid growth down more in line with the growth that the state realizes every year in state revenues, it would be ideal so that we are not consuming more of the state's new resources than what is being generated. That pretty much breaks into a little under $400 million in total expenses and $128 million in the state funds that are appropriated to the department. That is derived by assuming a 3.7% enrollment growth in Medicaid. That enrollment growth we're primarily estimating to occur in the low-income Medicaid program as compared to the age-blind and disabled, which we think will be relatively flat enrollment. That 3.7% accounts for about 50,000 new members on average per month. Part of the 128 also assumes medical inflation applied to the contracts that we currently have with our care management organizations, who, as you know, are our partners for Georgia Healthy Families and are serving about 1 million of our members in the low-income Medicaid and Peach Care programs. So we've assumed a medical CPI growth inflation to be applied to their contracts, just based on the assumption that these rates were set about 1.5 years ago, and we would expect that, just like we're seeing inflation growth in fee-for-service, that they too would be experiencing the same thing. And then I already mentioned the enrollment on the age-blind and disabled. That's expected to be flat, as is per member per month costs. Typically, we would expect per member per month costs in the age-blind and disabled program to increase every year. But because of the various administrative service organization functions that we've implemented in fiscal year 07, those will be up and fully running for July 1st, and we would expect that those functions would help to curb increases that we would typically see in the age-blind and disabled program on the per member per month basis.
Carrie.
Yes, sir.
And I hadn't gone through the whole handout, and you may address this somewhere else in here, but the total incurred expense, how much is attributable to enrollment growth, and how much is attributable to medical inflation?
If you'll allow me to cheat.
And you may be asking something that you got. If it is.
I do have this. It's on my notes to the slide. Would you mind if I
Yes, ma'am, go ahead.
Cheated, which you can cheat with me since you'll see. The breakout of the 128, you can see at the bottom. Enrollment growth is about 91 million of the 128, and the per member per month is about 37 million. Yes, 37 and 90. 90.8 million is the enrollment growth. This is in state funds. This is what adds up to the 128. So 90.8 in state funds for enrollment growth and 37.3 million in the per member per month increase. That's also state funds. All right, hopefully this slide looks familiar. I think we used it when we testified about fiscal year 2007. Just as a reminder, as we get into 2008, we have a hole in the base related to the loss of prior year surplus that we've enjoyed for a couple of years. Just as a reminder, this was fiscal year 2005 surplus that the department gained from excess intergovernmental transfers contributed to the department for the upper payment limit program. Based on agreements with CMS, the department and the state can no longer do that, and we actually ended that practice effective fiscal year 06. So for fiscal 06 and 07, if you will recall, in the Appropriations Act, y'all had appropriated how we were to spend those dollars in fiscal 06 amended, and then in fiscal 07. As we, of course, roll 07 to 08, which becomes the base, those dollars that were appropriated for 07, which was $166 million, are no longer available. So there is a hole there, as you can see if you look at the fiscal 08 bar on the slide. As you recall, the governor is addressing that hole by making appropriations available in fiscal year 07 that will roll into 08 and be used to fill that hole. We also have the $128 million in growth, and again, these are all in state funds, and you can see that would be above and beyond the 166. As the Commissioner mentioned, as far as what's actually in the '08 budget to address the 128, only $59 million of the 128 actually is in the '08 budget. The other two amounts are in '07. Again, those funds would go into reserves at the end of the year and then be available to be brought back into the budget in '08 for expense against that $128 million growth. You can see that $59 million increase in the Medicaid program on page 4, item 17.0.8.
I'm sorry, Representative Shaw.
Kerry, I look at this growth, and I thought the whole deal with the CMOs, as opposed to fee-for-service, we were going to save money.
Yes, sir. I would couch it more in terms of cost avoidance. If we go back to, let me go the right way here. You see that in total incurred expense projected to be 5.8%. Prior to our implementing Georgia Healthy Families, that number annually was more likely to be double digit. So in other words, up until the most recent time period, '07 and '08, we were seeing 10 to 12% incurred growth in the Medicaid program. So the savings are really a reduction in trend. I don't think we're ever going to see a decrease in the dollars needed for Medicaid, even on a per member per month basis if you ignored enrollment changes or enrollment growth. I think you're just going to see a lower increase in new costs. So that's why I say it's more of a cost avoidance of it's not as high as it could have been. It is a more moderate growth rate. So this is reflective of that implementation. That's a positive thing.
I still can't see a savings. Where's the savings? Go ahead.
Okay. All right. Another impact of another recommendation in the budget is to move some money between Medicaid and Peach Care. About $8.2 million in state funds would move out of Peach Care and move to Medicaid. This transfer is directly related to the Georgia Healthy Families program, and it's directly related to administrative costs that are a part of the capitation rates that we pay to the CMOs to cover both Medicaid and Peach Care members. I know I don't have to tell any of you the issues that we are facing as far as funding for Peach Care. The idea here is to move any fixed costs that are a part of the capitation payment made to the CMOs, to move that to Medicaid so that any changes to the Peach Care program do not jeopardize the CMO's ability to fund those fixed costs they have in operating Georgia Healthy Families. So you're seeing the reduction in Peach Care. What that would basically mean is you'll see lower capitation payments made to CMOs for Peach Care because of that reduction on the administrative side, and you will see a moderate increase on the Medicaid side. Of course, there's a lot more people on the Medicaid side than the Peach Care side, so it's not a one-for-one reduction in the PMPM, but nevertheless it is the same amount transferring. And you can find that item as I believe, a zero, no fiscal impact other than that being a transfer across families on page 4, item 17.0.13. All right, good news for us. We are appreciative of the fact that there are some dollars in the budget to do some program enhancements in the Medicaid program. Those kinds of enhancements have been far and few between for the department for a couple of years as we struggled to get our growth under control. And so now there are a couple items in the budget that will help to enhance the program. The first one relates to program integrity. This is on page 4, item 17.0.10. This is actually a transfer, so you would see this as a zero net change. It's transferring $1.9 million out of benefits and moving it over to admin. This will basically cover primarily two major things. One is 5 new full-time equivalents for our Medicaid and Peach Care for Kids program integrity unit. You see here the areas that these FTEs will be focused in, specifically claim screening for overutilization, adding to the capacity of the pharmacy lock-in program. And that lock-in program is related to members who may appear to be habitual users of prescription drug abusers, I should say. That pharmacy lock-in program literally locks them into one pharmacist so that that pharmacist can keep tabs on the prescriptions that person is being dispensed. And then finally, sorry.
President Stevens has a question.
So on this particular item, we're taking funds out of the kids and giving it to administration?
No, sir. We're taking funds out of benefits and moving it to administration to make sure that benefits are appropriately expended. This is all about preventing fraud and abuse in the Medicaid benefit program.
But it's coming out of the Peach Care?
No, sir. This is all coming out of the Medicaid benefits.
Okay.
Okay, and then the last of the 5 FTEs is related to license verification of providers as well as a provider linkage system. The bulk of the money is going into software purchase of a claim screening software program, again, to support the detection of fraud and abuse in the Medicaid and Peach Care for Kids programs. The next program enhancement is related to, again, Georgia Healthy Families. Federally, we are required to have an external quality review organization come in and do an independent review of the Georgia Healthy Families program. In that review, they're looking at quality, access, and performance outcomes. Again, this is federally required. These are new state funds of $3.9 million. You can see that on item 17.1.1 on page 4. On page 4, also 17.1.4 is a recommendation for a new, another FTE related to, well, not another, but a FTE related to an internal actuary. As we are, I think, becoming a more complicated and complex organization, we rely more and more on actuaries to do a variety of work for the department, everything from helping us validate Medicaid, Peach Care, state health benefit plan projections. Actuaries are also used to certify rates for the Georgia Healthy Families program as required by CMS. And certainly they do a lot of work for us as far as our financial statements are concerned. They every year perform incurred but not reported analyses that are used in our financial statements so we appropriately record liabilities. I think what's increasing, I mean, certainly all those functions have been around for a while, and so they are ongoing annual functions. I think what we're seeing now, particularly as an example, the Peach Care for Kids program, we're being asked to model different scenarios of what if we did this, what if we did that, etc. Frankly, we need the expertise of an actuary to help us do that. And by having one on staff internally, it helps us to turn that information around a lot quicker. Right now, we have to make sure we have a contract with an actuary, that actuary is available, and we just think we'll have a lot more flexibility with that actuary being on staff. I want to be clear, we're not saying that having one actuary on staff is going to replace or reduce our contract expenditures for these other functions that I previously mentioned. Rather, this actuary this particular position would be a complement to the work that's already being done. The next item relates to the service options using resources in a community environment, or you probably heard of it as SOURCE. This is one of our long-term care programs that's community-based. It's a case management program, and it helps to coordinate available community-based long-term care services that are provided through our various waivers. We've had this program for about 10 years, and in that entire time, we've never increased the monthly case management fee. It's always been it's always been $150 per member per month. The governor's recommendation would increase that up to $175 per member per month, or a $25 per month increase. That will cost about $2.4 million in total funds. And you should be able to see that on page 5, number 17.6.5 of the tracking sheet. The next,
Representative Hughley has a question.
Thank you. On the SOURCE program, can you tell me how those funds are, is there a formula for how those funds go out to the local areas?
we enroll source providers just like we would enroll a doctor or a hospital or any other medical provider. So based on them being enrolled in the source program, they bill us a claim just like any other provider would. Based on that claim, we're paying them $150 per member per month. As far as what's happening to the money once it gets to them, I'm sure it would vary by source site, but it's primarily paying for clinical and social workers that are performing the actual case management functions. And I think Mark's, where's Mr. Trail? Mr. Trail, would you like to add to that?
As Ms. Summers points out, each source site does handle it a bit differently. Some actually do pay a portion of the fee to the primary care doc that they have, who has meetings with them on a regular basis. But in general, what we're purchasing with that money is the more enhanced, intensive case management.
So it just depends on the number of people that are enrolled.
Well, the per member per month of 150 proposed 175 is the same for one person, one amount. Some source sites have several hundred, some have fewer numbers, but they're all paid for each member $150 per month right now.
Okay.
Representative Stevens has a question.
Before we move on, Mr. Chairman, I've got a question on 17.1.1, the $8 million for the review of the Georgia Healthy Families. Who gets that money and how is it distributed?
It will be, we will need to go through a competitive procurement to contract with this EQRO. So once that's identified, the money will be paid to that vendor via a contract. As far as what the individual terms are of, how that breaks down, I don't think we know that yet until we actually have the contracts done.
How did we come up with this number?
It is based on an estimate of what other states have paid for a comparable sized capitation program. We really have no experience in the states since this is the first time we would have done it, so we had to look to other states to give us some guidance.
Representative Smith.
Yes. How many do you anticipate bidding on this contract? You have any idea?
I do not. Do you know?
I don't know how many would, but it's not like it could be the usual QA type or auditing type. There are actually federal criteria that they have to meet, so it's a little bit more specific. So I would think the field would be a lot narrower, but I don't know how many are willing to come into Georgia to do it.
Representative Parrish.
Here, on a page or so back on your program integrity, the claims screening software, I think $800,000 is what you're getting there. Is that
Yes, sir.
Is that in-house or is that to contract with a contractor or another vendor to perform that service? How does that work?
If I may, I'd like to defer to Doug Colburn. He's our Inspector General who's over the program integrity area.
Representative Parrish.
If y'all don't mind, when another member of your team responds, we're told that you need to do it on this mic.
Yes, sir.
I'll try to balance this thing as best I can. That is for a system that would filter over the top of the current MMIS system. So it's a system that we would purchase. It would not be something that we would farm out to a vendor.
So it's in-house?
Yes, sir.
Chair, let me go back to Representative Stevens' question about the $8 million for the independent review, Georgia Healthy Families. Will that be an annual requirement?
Yes, sir.
So we'll spend somewhere in that neighborhood. Is this at the end of the day a report card, so to speak, on the CMOs or what? I mean, that
Could be used that way.
Yes, I think it's federally required, so it certainly meets certain standards that CMS wants to see as far as how the state is contracting with care management organizations to ensure access to care for the members that are served by those organizations. But I think that certainly the state could expand upon that and require our own things that may be above and beyond what the feds require.
But you all are doing this, I mean, to some degree in-house. I mean, we heard yesterday from you all in terms of where you were and all that sort of stuff. But so this is obviously above and beyond what you all are doing. Somebody else looking at it and giving, if you will, an independent.
I think that's exactly the key here, that this is independent. I think what that suggests is it would not be unlikely for them to be looking at the same things that internal staff will be looking at. The benefit is you're going to have an external organization that is independent of the state, making notations and coming to judgment about how well they're doing.
And since it's a Fed requirement, I would assume that they would also naturally assume that whatever the findings were, that you all will take appropriate action. Is that correct?
Yes, sir. I think FFP would be at risk if we did not.
Okay, thank you.
Okay. All right, the next part of the presentation relates to the state health benefit plan. And just very quickly, just to give you kind of the fiscal status, we expect in fiscal year 2008 our expenditure growth to be about 12.7%. Unfortunately, we have not been as successful in bringing that trend down into the single digits like we have with Medicaid and Peach Care. And of course, we are continually looking at better ways to manage the health care in order to try to bring expenditures down. Some portion of that expenditure growth is related to enrollment. There's just more people eligible for coverage by the state health benefit plan, and there are more people who are taking or actually electing to take that coverage. Just as a good example, at the beginning of September, there are thousands more teachers that come into school systems across the state to deal with class size reduction requirements, et cetera, just population growth. And so all of those teachers are eligible for state health benefit plan coverage. So about 2.5% of that 12.7% growth is solely attributable just new people that we're covering. The other 10.2% is related to a per member per month increase. This can be a combination of things, but primarily it would be utilization increases, changes in the case mix of services being provided to members. In the case of increases, that would suggest that cases are more complex and therefore more costly. And then certainly medical inflation and the cost of new technology would be a part of that as well.
What is your total number of covered lives projected to be in 08 versus 07?
We're thinking about 8,000 more right now, and the most recent number that I've seen is we have about 669,000 covered lives, which would be members and their dependents.
And that's that's currently?
That's a most recent snapshot, yes, sir.
And so you're projecting that to go up by 8,000?
Yes, sir.
Thank you.
The 10.2% per member per month growth is actually very comparable to other large employer insurance plans in the private sector. What our actuaries tell us is that if you can get per member per month growth down to maybe around 7 or 8%, that's very aggressive and probably the best, at least at this point in the healthcare or the private insurance market, the best that you would be able to do. So we obviously have some room for improvement, but we really are not that far off from what the rest of comparable plans are experiencing in their growth. All this is to say that there's a $215 million difference between what we expect expenditures to be in fiscal year 08 and what we expect the existing revenue contribution sources to be for fiscal 08. So before we even get into what the governor's recommended, all that means is either we have to increase revenue by $215 million, or we need to reduce expenditures by $215 million, so that you could get those 2008, the 2 points on the chart to match. Revenue, is typically growing maybe about 2 to 3%, and that is really related to growth in payroll, and most of that growth in payroll is a result of pay increases, although certainly at the local Board of Education level, some of that growth is related to the fact they just are hiring more employees.
If you don't mind, that also, by lowering that annual growth rate, that's part of what you have to take into account when you're figuring the OPED thing. I mean,
Yes, sir.
If we look at 10%, or actually 12% expenditure growth, and somebody's got to project that out 15, 20, 30 years, however long it is.
30 years,
and that's part of the formula that determines what that huge number is going to be. So naturally, if that number comes down, then the number for OPED also comes down.
Correct.
Pretty substantially, doesn't it? I mean, if you cut the growth rate by 2%, what we'd have to set aside would be huge.
Yes, it would.
Okay, thank you.
As far as the governor's recommendation for fiscal 2000, he's taken the approach of increasing revenue by $215 million. So what that means is there are no recommendations related to expenditure reduction. So the $215 million is generated a couple of ways. The first way is related to the employer side, and the commissioner alluded to this earlier. Traditionally, we try to have the premium sharing strategy be somewhere around 25-75, with the employee picking up 25% of the cost of the plan, and then the state or the employer, local Board of Education, picking up the other 75%. So we're constantly looking at that ratio, and then a little bit later I'll show you kind of what that ratio has looked like over time. So the governor's recommendation has $176 million, which you can see on page 5, number 17.8.1. Actually, that number shows $276 million. 100 of that is for the other post-employment benefits, which I'll cover in a little bit. But the 176 of that is related to increasing the employer's contribution. The way that will be achieved is by increasing each agency that participates in the plan, increasing their percent of payroll that they're required to contribute by 1.821%, and it does get down to that level of significant digits. So we'll be going from the current 16.713% up to 18.534% for the percent of payroll that's contributed on behalf of active state employees as well as active teachers. There's also an additional $9 million that will cost the legislative and judicial branches by having that payroll, that percent of payroll increased. Right now, that $9 million is not in the governor's budget recommendation. As I understand in speaking to OPB, the governor was addressing the executive branch and did not have the liberty to provide those dollars to the legislative and judicial branches in their budget recommendations.
Could you repeat that?
No, I cannot repeat that. I'm sorry. As I understand, he was providing the funding for the executive branch, and the assumption is the judicial and legislative branches would cover those dollars.
Out of what?
I can't answer that. I don't know.
So the governor provided this money in his budget recommendation
for executive agencies.
Sets what the revenue is going to be, but somehow didn't for the judicial and legislative, and
that's correct.
By inaction has instructed this General Assembly to come up with money out of something else that he has recommended.
Well,
is that right? I mean, so we don't have anything to do with the revenue estimate. We would have to take this money out of something that the governor has recommended in some other arena. Is that correct? Or
That's
what?
correct.
Okay. I just want to be clear.
I think you got clarity there. Yep.
Thank you.
The second way we will be generating the $215 million is related to increasing the employees' contribution. The premiums for employees, and this would be all members, both currently active and retired, their premiums will go up by 10% based on whatever plan they're in, beginning January 1st, 2008. Just to give you an idea of what that practically means for state employees and for teachers who are also expected to get pay raises, and I think we hear a lot about a 3% pay raise offset by a 10% increase in health benefit or health premiums for the health benefit plan. That's a little like comparing apples and oranges, frankly. The 3% is applied to their entire salary. The 10% is being applied to the premiums that they pay. So we try to show you on this chart is just based on hypothetical 3 different examples of a fiscal year 2007 salary, indicating what the 08 salary increase would be. And in this chart, we use teachers. Their pay raise is proposed to be effective on September 1st of 2007. You can see it's somewhere between $750 to $1,250, depending on the salary level. We used also for this example an assumption that such an employee would have family coverage in the PPO plan. Based on that going up by 10% in January, you see that would cost $130.32 for fiscal year 2008, so that's a 6-month cost. When you compare the two, you see that instead of 3% increases, it does bring it down to a net of anywhere from 2.1 to 2.2%. And again, these are just examples for the salaries. Of course, at least for teachers, this would not consider those that are qualified for step increases based on their tenure, which we understand may be as much as another 3% above and beyond the base 3%. Obviously, that is not applicable to state employees, and state employees are not slated for their pay increase until January, which would also be the same time that the health benefit premiums increase. I mentioned earlier that ratio of the 75-25 that we try to maintain, and you can see hopefully in this slide, these are the percentages the employee has paid, and we've used the PPO. Of course, we have multiple plan options for members to pick from, including the HMOs. We also have indemnity plan, choice options, etc. But for the PPO, it is the PPO options are available statewide, so we thought it was a good plan to use. As a comparison or as an example, you can see that the percent that the employee is paying in premiums has been decreasing since fiscal year 2004. For family coverage in calendar year 08, the split is expected to be 24% for the employee and 76% for the state.
So it's what you're showing is a decline in the employee share of the total premiums, both for single coverage and family coverage since 04. The reverse of that is obviously also true, and that is it not? And that is that the employer or state part has been going up.
That's correct. All right, the other post-employment benefits component. The governor has recommended $100 million to begin to address the annual OPEB liability for state agencies. You can see this as a part of item 17.8.1 on page 5. Again, it's combined with the $176 million that would be used for the employer's increase towards the cost of the plan in 08. We just completed our June 30th, 2005 valuation for OPEB liability. I think you might have heard through various reports a number based on our 04 valuation, which was somewhere around $17 billion. That's for just state health benefit plan. There are other agencies that have OPEB implications or have OPEB liabilities, specifically the Board of Regents and their health benefit plan. I believe they're somewhere between $2 and $3 billion. And there is also an OPEB liability related to life insurance that's offered through the employee retirement system. Our June 30th of 2005 valuation actually reduced our OPEB liability from the $17 billion that had been reported from the 2004 valuation down to $15 billion. That's actually a result of the impact of Medicare Part D. Medicare Part D, as you know, started in January of 2006, and while the valuation is a snapshot of the number of members covered in the plan as of the end of the valuation period, which in this case is June 30th, 2005, the actuaries, when determining OPEB liability, are actually able to consider subsequent plan changes that may change the prospective liability. So they were able to consider Medicare Part D, and that actually reduced the liability. Although the net change is $2 billion, it actually brought it down by over $4 billion, because every year that we do not fund an OPEB liability, it keeps continuing to go up. So the OPEB liability would have probably been somewhere in the $18 to $19 billion range had it not been for that offset of Part D. So let's see what else.
Do they do that? Will that be a new figure annually?
Yes, sir. Every year we are required to update it based on a more recent period. The GASB requirements say that the valuation period has to be within 2 years of the date that you use it on your financial statements. So, for example, we will have to record GASB 43 liability, which is exactly this, for the plan in fiscal year 2007. So the oldest time period that we could use was 2005, June of 2005. And incidentally, this is consistent with the same valuation period that is used for the pension plans with the ERS and TRS and the two teachers and employees retirement systems, so that we're all utilizing the same information and recording those liabilities. Fortunately, we don't have to pay the full $15 billion all at once. GASB is so generous that they let us pay it over 30 years, kind of like paying your mortgage. Unfortunately, the mortgage payments are quite pricey. For fiscal 07, the contribution would be $1.26 billion, and basically GASB said you would pay that amount each year for 30 years as a way to completely satisfy the $15 billion liability. The way that the $100 million is being generated and being actually contributed to the health plan is also through the use of percent of payroll, much like the $176 million that's being used to increase percent of payroll by almost 2%. The governor's recommendation takes the $100 million, spreads it out across state agencies so that state agencies can pay an additional 4% almost 4.3% to be exact, into the plan as part of their percent of payroll contributions. One thing we definitely would want to make clear is that, because we've certainly heard from various groups a big concern about changes to retiree benefits for fiscal year 08 and really for calendar year 08, which is the calendar year 08 plan year. There are no changes proposed to what retirees get for coverage in terms of the scope of coverage, or there are no proposals to charge them something different than what they are currently being charged, other than the 10% 10% premium increase that all members are being asked to pay. So we're not treating them differently in any way, and I know there was some concern about that, but we wanted to make sure to really emphasize that point. Certainly there is a lot of dialogue to be had about how to address this. Ultimately, it would be important for the state to have a good plan. Bond rating agencies will look at the state's plan to address OPEB. The first steps really are the disclosure of how much is it, and that is part of what The first step is for fiscal year '07, we will have to record that. In fiscal '08, where the $100 million is being contributed into the plan, that actually would be segregated and put into the Retiree Health Care Trust Fund, which the General Assembly created last year, so that we can separately account for those assets and get credit towards the liability. Any other questions on state health benefit plan before I get into the health care access and improvement items?
Yes, excuse me, I have a question. Representative Hughley.
Thank you, Mr. Chairman. My question, however, goes back to Medicaid, if you don't mind.
Okay.
On item 17.6.8, we say we're replacing state funds with fees earned by DHR for the newborn screening activities.
Yes, ma'am.
Would you explain that one for me in terms of where the fees are coming from and how we're able to take this amount out of that fund?
As I understand in talking with OPB, the fees are coming from what is actually being charged to the hospitals. In other words, public health in performing these newborn screenings for metabolic disorders, they are assessing a fee for hospitals, and part of those fees will then be used to pay the department, who will turn around and reimburse hospitals for those births paid for by Medicaid. So it's somewhat of a transferring of funds, if you will.
So these are the screenings that we required in our legislation
Yes, ma'am.
last year.
Mm-hmm.
So what you described sounds like a shell game, one, but it sounds like the money's going around in a circle. Never mind. Okay.
I can only tell you what I know from OPB.
Okay.
That's the way they explained it to me.
Thank you, Mr. Chair.
I think the bottom line is we are reimbursing the hospitals through Medicaid for Medicaid births, and the program is being implemented as intended. In other words, those screenings are being done. Yep. Almost jumped ahead of myself. For the healthcare access and improvement programs, there's several new initiatives that the commissioners already mentioned. The first one is related to health information technology. This is $1 million in state funds. You can see this on page 4, item 17.3.1. This is the transparency initiative that she mentioned. This is creating websites that provide health information to consumers about what things cost and other quality information that may be useful for them as they make their selections for where they receive their health care.
Representative Stevens.
Can you expound a little bit on the transparency as far as the PBMs go? Is that going to be a piece of that puzzle?
Sunny? I thought it was more getting data from the pharmacy, but let's get somebody who is running the show. Where is it?
And while you're coming up to the microphone, and I know that everybody won't be speaking to the mic, PBMs have been classified at times of billing the payor one price for max and sending pharmacies another price for max. I just want to make sure this $1 million is going to be put to good use and that we get a true cost of what the payor and the payee are being billed.
Right. Well, what we have is we have two decision support systems that we're considering to use. One is for the state health benefit plan that handles claims for the state health benefit plan and the PBM, the pharmacy benefit management aspect of that. We also have another decision support system that has Medicaid claims, and it also has Medicaid pharmacy information in it. We want to draw on that information to present costs currently for any claims that are being submitted. We want to be able to present those claims, present that information so that consumers can log into a website and determine where the best price might be for medication or for a procedure to be performed at a hospital.
Okay, that's kind of outside, I guess, of where I'm going, but I'm looking at the PBMs themselves to make sure that we, the state of Georgia, the taxpayers, are actually paying exactly what we think we're paying by the PBM, and there is no shell game going on as far as what the pharmacy is being billed or what the provider is being billed as a piece of this action versus the people that are paying the bill.
I think that's probably more of the Inspector General, their audits more than the transparency.
All right.
Okay.
Sir.
Representative Higley.
Mr. Chairman, I'd just like to know where were we spending this money before we decided to come up with the website? And is the information that's going to be on the website available in other places out in the universe somewhere?
Representative Higley, I'll share your question as well. Plus, it says a pilot. I mean, I'm just.
These are new state dollars. They're not redirected from any other or current existing program. And as to the question is whether or not this information is available at other sites or other resources, I have not seen anything in the state of Georgia that is consumer directed in providing the information that we hope to provide.
Representative Parrish.
Help me understand this just a little bit more on this information transparency. There's going to be a program that's on the website. If you're sick, you're going to look on there and determine which doctor you want to go to, because one doctor is going to charge $30 for an office call, and one is going to charge $25. Or if I decide I need an appendectomy, I can get one at $300 at this hospital and get it for $200 over there. Is that when we're talking about pricing? What?
No, I think we're talking more about in the instance, let's say, like someone like me who needed her knee replaced. I might want to actually look at the quality measures as well as the costs on what the different facilities within my reach would provide. So first thing I'm going to do is find out what facilities are covered by my health insurance plan also, and then I can figure out co-pays and all other stuff. But I'd like to know whether or not Hospital A has a better prevention of sepsis rate or reject rate, or maybe they have more outpatient rehab or some other thing that I would like as opposed to Hospital B. It's not just a matter of dollars with it. You also have to put in the quality as well as the customer service features.
Have we had anything like this in the past?
I'm not aware that you have.
Representative Stevens.
Thank you, Mr. Chairman. Would this also include things like staff occurrences, that kind of stuff that you could get on the web and see?
Yes. I think what we would do is we would choose things that we know that consumers would be most concerned with. You know, when you go into the hospital and you fill out a consent form for a procedure, and it says, you know, you agree to have your hip replaced and you're aware of 1, you could die, 2, you could get overwhelming infection, 3, you could bleed to death, all those kind of things. Those would be some of the things that we would try to have some relative measures on so they could compare hospital to hospital. But the other things are, like I said, some of the customer service concerns that patients may have, like can I stay in your hospital and do my rehab, or do I have to go outside of that? Do you help me with getting any kind of support at home, those kind of issues? So there's an opportunity for a hospital that really goes out of its way to provide additional services to actually, I guess, promote it and be upfront about it, as well as display their data about sepsis rates, infection rates, post-op complications.
Representative Gardner.
So would another function of this system be if I were taking medication for a chronic illness, would I be able to go to this site and see that I could go to Efforts and buy it for one price and CVS and buy it for another price? Would that information be on this site?
When we did the pharmacy piece.
When you get the pharmacy?
When we do we're going to do each industry. You just start somewhere with it. So there's a pharmacy piece, there'd be a hospital piece, there'd be a nursing home piece.
And have you decided the priority list?
I have a whole crew of advisory council members who are going to be making those decisions. Yes.
Representative Sheldon.
You mentioned infection rates at hospitals. Where would you get your data for this? Would we require hospitals to submit this, or?
We are trying to decide which is the best approach, whether we could get them from the hospital directly so that they would have an input and they could actually do risk adjustment and everything else to make sure that they're feeling that their data is being respectfully reported. We would also be able to get information from Office of Regulation. Folks that actually, regulatory services is different in every state, but the organization that actually is licensing these facilities as well, because they would have a history of any deficiencies, not near misses, but you know what I'm trying to say, medical errors, that type of thing. Yeah.
Would you expand a little bit on when it says pilot, and I see in your handout that it's got 4 projects: health information exchange, electronic health records, e-prescribing, and so forth. I mean, when you say pilot, is as it relates to this, I mean, website development, are those the things that you're going to what do you mean by pilot?
Okay. We're talking about, this is actually 2 distinct efforts. One is the transparency website and the information for consumers. And then separate is the work to be done to actually encourage further the development of health information technology, electronic health records, e-prescribing, those type efforts in the state itself. So there's 2 distinct bodies of work that are being done with the same advisory council advising department on them. The 4 pilots that we are envisioning, and again, this is just starting this work, is what we're going to do is actually provide matching grants to community health care partners who are willing to work together to build electronic health record type work in an interoperable setting. So they're going to submit their application in. We choose who we think has the best proposal and provide them with matching grants to encourage them to continue on with the work. But this is not something that we would anticipate where the state would be funding the entire state's electronic health record system.
I support what you're trying to do here, and that's certainly the direction I think that we in healthcare need to be going. And I think as health savings accounts and other things become more of the mix, this is a vital part of that, because in order to make an informed buying decision, you got to have this information. And I applaud where you headed. We're just trying to understand, because the website, obviously, that wouldn't be a pilot. That'd be available to anybody got a computer.
That's true. That would be statewide, and that's a matter of us defining what we'd like to provide to the consumer, getting that up and going, and keeping it up to date.
Representative Gardner has a question.
I'm concerned about each hospital developing its own format or platform. Is there a national standard, or are we going to have a state standard?
There are actually
platform?
national standards already being developed. President Bush had his own national coordinator who was working on national standards, and I believe there was a health technology community study that's also developed. So the feds are already developing some of the national standards. Right now in the state of Georgia, individual hospitals are developing their own things. And I think what we thought we could use this effort for was actually encourage them to work together or to work across different types of health care providers and payers.
So would they be tying into the national standards
Yes.
that's being developed? Ready to go on? Okay.
The next part of the Healthcare Access and Improvement Program relates to some reductions in one-time funds that were made available in fiscal year 07 that are being discontinued or deleted for fiscal year 2008. You can find these items on page 4 of your tracking document, 17.3.2 and 3, as well as .5. $150,000 for radiation equipment for Oconee Medical Center, $200,000 for the Southwest Georgia Cancer Coalition, and $750,000 for one-time startup funding for the statewide electronic medical record system for primary health care centers.
If you don't mind me asking one quick question. The $200,000 for Southwest Georgia Cancer Coalition, that's being shown here, is it not, as general funds rather than tobacco funds? Is that right?
I believe these are all state fund reductions.
Yes. Okay.
Yes.
But the other part of funding that goes to these regional cancer coalitions comes out of tobacco funds, doesn't it?
Yes, sir.
Thank you.
The next item is another new initiative related to rural Georgia and healthcare access. Speaking of tobacco funds, this is a recommendation for $1.5 million in tobacco settlement funds. You can find this on page 4, item 17.3.4. As you can see, these funds would support the Rural Health Safety Net program, which is basically ensuring that we have regional systems of health care where providers like community health centers are coordinating with various regional hospitals to provide an entire network of care for obviously particularly rural communities. You can see what the outcomes are. Obviously we're looking to improve rural health, make sure that safety net is strong and continues to be viable, and is also an economic development item, as it ensures it's obviously one of the industries in Georgia. You can see these dollars are expected to be used to provide planning and development. There's a phase-in for 3 to 5 regions, and these dollars would be awarded through competitive application process.
So this is planning money?
Yes, sir.
And does it go to...
And some development money.
Does it go to the regions, or would it go to a vendor, or, what, who?
If I may, I'd like to defer to James Peoples. He's with our, or do you want to speak to him? Sorry.
Come around, but to answer your question briefly, it's kind of the same thing. It's where we would get a group would come in with a proposal. It's kind of like a grant, basically, we would be giving. So it's not that we're paying a vendor to do this, but we're actually trying to get rural hospital and healthcare provider to come together here. James?
Mr. Chairman, we found that by trying to improve access and to try to help the rural health care network in Georgia, that systems of care is the route that we think may be the best way to go. So these dollars would provide funds to communities that want to partner together on a regional basis to build those networks of care and build those systems of care. So you could have multi-counties coming together as one group with hospitals, community health centers, rural health clinics, all together to try to make the safety net stronger in rural Georgia.
So it would more likely be, as the commission I think said, like a grant type thing based on a competitive process.
That's correct.
Okay.
I think we've already gone over this particular slide with you before. We were just trying to give you kind of the idea of where we are in terms of what percentage of our budget is administration, and this really was just an FYI as you consider our request for primarily the FTEs that are in both the 07 and 08 budget. The next item relates to a change in the programmatic budget structure that's being recommended. I think you recall that back in the beginning of fiscal year 2006, in particular, the Medicaid benefit line item that had been actually the way we paid Medicaid benefits, or at least budgeted for Medicaid benefits, had been in place for quite a while. That was broken out into two programs when we moved to program-based budgeting. One was the low-income Medicaid program, and the other was the age blind and disabled program. The governor's budget seeks to consolidate those once again into one programmatic budget called Medicaid, but in the interest of transparency and the ability for both the department to separately track expenditures by member type, as well as for both the governor and the General Assembly to see individual expenditures for these groups, he is proposing to have sub-programs that are comparable to what used to be programs. So I know this is kind of a busy slide, but if you'll bear with me. On the left is the current program structure. So again, you see age blind and disabled and low-income Medicaid programs being separate. Nursing home provider fees is also a separate program, even though technically it's really a financing source for payments to nursing homes for Medicaid services. And you also have the Indigent Care Trust Fund, which right now houses the nursing home provider fees. It also houses the quality assessment fees we collect from care management organizations, as well as funding for the disproportionate share hospital program. All of those really are Medicaid-related programs, so the recommendation is to put them all together, but you can see still have them broken out in sub-programs. These changes are budget neutral. It is simply moving money from one bucket to another bucket. I also have some account adjustments that I'd like to go over with you. The CMO quality assessment fees that I just mentioned, these are dollars that are, or 6% of revenue is assessed as a quality assessment fee to the Georgia Healthy Families Care Management Organizations. They pay those dollars to the department via the Indigent Care Trust Fund, and those dollars are used as a state matching fund source for both the Medicaid and the Peach Care program. In fact, those dollars are used to replace what used to be the excess intergovernmental transfers that the department used in fiscal 05 and prior to help support Medicaid and the Medicaid program. These account adjustments are just showing what we would expect the collections for these CMO fees to be in fiscal year 07 and 08. You can see the fiscal 07 bar reflects what's currently in the budget. I think we already talked to you about the adjustment that would change it for amended 07, and then in fiscal year 08, you can see we're expecting $158 million in quality assessment fees on behalf of the Medicaid side, and then another 22 or so in the Peach Care for Kids world. All right, and finally, in summary, you can see the governor's 08 recommended budget has entire departmental budget expenditures at $11.7 billion, with 2.5 of it coming from state and tobacco funds. That's a 5.4% increase in the state fund budget as compared to the base 07 budget. That's $123.9 million in additional state funds, and we've tried to break it out so you could see where that 123 adds up to. Certainly a majority of it is the Medicaid growth that we talked about, as well as the increase for the provider fees for nursing homes, as well as the quality assessment fees that are levied against the CMOs. $6.5 million for administrative support related to the EQRO for the Georgia Healthy Families program. $14.2 million in Peach Care for Kids, which really is just increasing those or reflecting those quality assessment fees that we collect on that related to Peach Care revenues, but that being offset by that administrative transfer that I discussed with you earlier. And then
Excuse me, Representative Stevens has a question.
Thank you, Mr. Chairman. As you're backing up on administration fees, and it just occurred to me a little bit on the bar graph that we've got here up through 2008 at 3.5%. Does that include the admin fees for the CMOs?
No.
Can you get for this committee from 02 to 08 a cumulative breakout of all the admin fees that accumulates from all the CMOs and all the grants that we give out for the different prime directives that have an administration fee attached to it that used to be handled by the department.
Okay. You understand what
I understand.
Yeah, just a total admin fee for everything that we're farmed out, essentially.
The chart will look primarily the same except for the last 2 years, because all of our contracts, so everything like our third-party administrator, anything we contract for are included in the admin number that you see on that chart. What would not be included would be the component of the capitation payments that we pay to CMOs that helps to cover their administrative expense. CMS recognizes those as a benefit payment. So you wouldn't see any adjustment to 02, 03, 04, well, really up through 06. It would really only be 07 and 08 that would be adjusted because we haven't had a CMO program.
As I recall, though, that runs about 10-15% admin fees on those CMOs.
Right. I'm just saying that the only part of the chart that's going to change when we add that information that you've asked is the last 2 years.
Okay.
Because the first years already include everything.
And I think what Representative Stevens is getting at, if you're going to compare apples and apples, you're going to need that number in there. But for the last 2 years, you're right. That's when CMOs came into existence. But that admin went away here, but wound back up someplace else.
And also the huge increase for the state health benefit plan of $275.9 million. Again, that's for OPEB, $100 million for OPEB, $176 for the employer's contribution towards the increase in the cost. Those are actually other funds in our budget because we are collecting them through from other agencies who participate in the plan. And I believe that concludes our slides.
I have a couple of questions. Indigent Care Trust Fund. The proposed regulations to taking place if they happen in September. What does this budget contemplate as it relates to Indigent Care Trust Fund?
It does not address the proposed new CMS rule that would basically wipe out the DISH and UPL program as we know it today.
But I guess my question is, it doesn't appear to do. We've had net $250 million. Coming through this thing. $400 million to him. It just doesn't appear in the budget, or what?
Well, I think the actual 08 budget, there's no changes. The governor's recommendation does reflect what have been historical DISH payments. So you should see in there federal funds of the $250 million. If you look into the Indigent Care Trust Fund in the base.
Is that in the base?
It would be in the base. I think what the commissioner's saying is any changes to financing to get those $250 million have not been otherwise addressed in the budget at this point. But yes, the total is in there.
But what they have been doing in the past is in the base?
Yes, sir.
Okay. Second question. Let's go to Peach Care on page 5. I just want to be sure I understand what this budget document contemplates. And I know this, I think I know that this budget document doesn't contemplate, well, I guess it does contemplate the federal government coming up with that share of the money. Is that correct? The $60 million state funds, $300 million.
What's in the governor's recommendation for fiscal year 2008 is a status quo budget. So it's really just carrying forward the base of 07. It does not contemplate any changes to the Peach Care budget in order to address any federal fund shortfall, nor does it add state funds to supplant federal funds that may be necessary to fully fund the status quo.
But it doesn't contemplate any future growth in the program or anything. It just simply
It just carries forward.
Help me understand line 17.10.5, 17.10.5. What does that do? What's the 56 million in brackets? What does that do?
Did you say 10, 17,
on
10,
page
5?
5, 17.10.5. What does that do?
Okay. Oh, okay. But isn't this the roll forward that's being... Okay. At the end of fiscal year 06, on the state fund side, from a state fund perspective, because Peach Care has always been fully accrued funding, in other words, unlike Medicaid where we've been on a cash basis, at the end of the year we always have state funds left over to cover IB&R. So those dollars roll into the next year and are brought back in as a reserve to pay IB&R. What this is doing is reflecting that we are unlikely to have such state fund roll forward in fiscal year 08. We've already moved to full capitation for the Peach Care program. We really should have a very nominal amount of IB&R. And frankly, this is an accounting adjustment to say you're not going to have a huge IB&R reserve rolling forward into 08 and being expended. So it's just, I think it's really a function of budget net. And Margie, if you want to kind of speak to that. But there's no practical, it's not a cut to the program. It's really just an accounting of IB&R.
Representative Gardner.
Would you mind going back to page 8 and explaining page 8 to me again? I just somehow did not understand what you were doing.
Okay.
Page 8 of your handout.
Oh, stuff like
the Department Administrative Transfer.
Yes.
This is the Peach Care Medicaid.
Yes. Right. As actually Representative Stevens just pointed out a little while ago, part of the capitation rate that we pay the CMOs for both Peach Care and for Medicaid includes a consideration that CMOs have administrative costs. They have both fixed costs and they have variable costs, which, fixed costs, obviously they have to have that to operate regardless of the number of members they're serving, and of course variable costs would vary depending on the number of members they're serving. Okay. Because of the issue with Peach Care and the concern about not having enough federal funds, one of the ways to help address that, certainly is not going to address all of it, would be to try to reduce CMO payments or the capitation payments made on behalf of Peach Care members. We can do that by saying to the CMOs, if you have fixed costs, move all of that fixed cost and include that in your bids for fiscal year 08 rates so that all of your fixed costs are covered in the Medicaid program. So that the only piece that's left when we make a capitated payment to the CMO for a Peach Care member, the only part of that capitation payment that's admin is related to variable admin. So in the event that, and this is obviously worst case scenario, but let's just say if the entire Peach Care program went away, it would not reduce the amount of revenue that the CMOs need to operate their administrative functions, because that would have all been covered in the fixed rate that's being paid through the Medicaid.
So it's moving it into the Medicaid department.
Right.
Or portion of this.
Right. So you'd have a reduction in the capitation payments paid on behalf of Peach Care members, and then you'd have an increase in the capitation payments made on behalf of Medicaid members.
Can I ask one more question, Mr. Chairman? In the same, on the same issue, I understand that there were about 100,000 children fewer that were part of the CMO program than anticipated. How is that reflected in the payments to the CMOs? I mean, you thought they were going to have 1 million, and maybe they only had 900,000, or I don't know the numbers, but
at this point, there's been no adjustment to their capitation payment. We are simply paying them for less members, but we're saying paying the same amounts as was competitively bid by them in their initial bids, and then subsequently negotiated with our actuary for the actual final rates that are being used now.
But since it's a per member per month, they're only getting for the number of children that are actually
That's correct. Those that were carved out, like the foster care children, for example, we are not paying the CMO for those children. We are covering those children through fee-for-service.
Or those children who didn't get re-enrolled because of the new programs to determine eligibility, they're not counted.
No, it's actually the child who was in it.
The child who's actually enrolled. Okay. Thank you.
Mr. Chairman,
Yes, ma'am, Commissioner.
would you like us to go ahead and talk about the citizenship and enrollment?
Yes, I think that'd be a good idea, please.
Okay. If it's okay with you, I'm going to sit right here.
Commissioner, well, one second. Representative Parrish has a question first.
Before we get to that, I want to ask you a question. It's not specifically about budget numbers, but I think it relates to it. And, you know, in some of our previous meetings, we had some representatives from the CMOs who came in and talked to us, and they told us how well the program was working and the percentage of claims they were paying and this sort of thing. And then we had some of the providers that came and sounded like maybe it wasn't working quite as well as we had heard earlier. And I guess my question to you is from the department standpoint, could you kind of brief us a little bit on your perspective about how it's working, taking into account the CMOs, the providers, and the clients? What sort of feedback you're getting
I would have to tell you that since the initial rollout in June and then the second rollout date in September, the number of complaints and concerns and issues has decreased, which is always a good thing. I've also noticed that a lot of the concerns are now focused more on prior auth or medical management issues, more so than some of the claims processing issues that we initially had to deal with the first couple of months. I found that more providers are actually contacting the plans more directly, as opposed to initially we did a lot of intervening and did a lot of basically holding hands on both sides and getting folks to talk to each other. I found that some of the staff for the CMOs, when they first came in, a lot of them were kind of new, are learning and are becoming much more responsive. Some of the providers, when they first came in, that was a chief concern of theirs because they weren't sure that anybody actually knew how this was supposed to run. I've heard more compliments in that area in terms of things improving a little bit, but still acknowledging that there's still obviously some work to be done as well. Some of the initial concerns that I heard about, I have not seen one dime of payment kind of thing. I think I've heard much fewer complaints in that area. I think when they do come in now and they tell me that they're not getting paid, we've got to set it up so that we bring both parties in. I get information from both sides, and I can see what's getting paid and what the explanation is for any delay or any non-payment issues. So I think overall it has improved, and I know that you can appreciate that my eyebrows and hair have grown back since starting this endeavor. But I think that we are into, how many months has it been now? It feels like a couple of years. But we are not quite through that first year yet, and I anticipate we still got some work to do. What I'd like to do, if it would be helpful to you all, is we have pulled together, actually I'm going to give Mark Trail the credit for pulling together information sheet on eligibility trends as it relates to income and citizenship verification. And also, I think I left at your seats some information about the federal law, the Deficit Reduction Act 2005, that actually addresses the requirement for citizenship verification to now include documentation. I also put in there a copy of the Congressional Federal Register where it talks about the newborn issue that I know most of you have been briefed on as well. So, Mark?
Chairman, member of the committee, it's my pleasure to be with you today. I do want to draw your attention to a couple of documents, mainly to point out what they are and maybe point you to places in those documents that would be instructive to you. First of all, you do have a color version of this form that says eligibility trends up on the top. This does give a summary of what is actually occurring within our ranks, if you will, in determining eligibility. And I want to draw your attention first to the graph in the middle entitled Family Medicaid and explain that graph just a little bit to you. I know you heard some testimony yesterday that related to some of this activity, and I wanted you to have the actual data of what's been occurring. I do want to point out, as we start to have the conversation about the actual data in this graph, that Georgia started implementing the requirement to document citizenship back in January of 06, which was actually a little bit before the federal requirements came into play on July of 06. But in addition to that, Georgia also began requiring documents for income verification as well. So there was two policies that went into effect in January of 2006. So both of those policies are reflected in some of the numbers that you see as eligibility determinations have been made. The graph in the middle entitled Family Medicaid reflects actual denials that have occurred within Medicaid, and it shows it to you over time. And I think you can clearly see, first of all, let me kind of point out which bar is which. I apologize for the small size. We are tracking these denials in a couple of ways. One is, of course, the overall denials, and then we're also able to track denials as it relates to income and citizenship documentation. But I need to emphasize to you that what we know about that as we're tracking it is, number one, they're clumped together. So I can't tell you the difference, which ones were may be deemed uneligible because of something related to income and which ones may be deemed uneligible because of citizenship. But I at least have those two together. The other thing that we are not able to distinguish for you in bringing these numbers to you is whether the denial was a result of them failing to produce these documents, or if they produced the documents, the result was they were not eligible. So, for example, if you might be denied if you were not able to produce documents documenting your income, but it might be you did produce those documents, and it could be that the result was you were over income, so as a result, then your application was denied. So I wanted to point out that information as we're looking at these particular data points. The second line from the top in the graph are the total redetermination denials. Now, we're tracking denials both for redeterminations. In other words, somebody has been on Medicaid already, and it's time for them to be their eligibility to be redetermined. That's what we're referring to as the redetermination period. Then, in addition to that, we're also tracking new applicants. So we've got a line that shows those that are denied based on a redetermination, and then we also have a line showing those that are new applicants that are being denied. The two lines that track across the top, the very top line is new applicants. The second line going across, I apologize, my bifocals don't work so good either, so I got to get my head just right. But the diamond shaped are the redeterminations. The one on the very top that are the triangle. Thank you. Can't even remember my shapes. It comes with bifocals. But at any rate, the one on the very top has to do with new applicants, the one under that redetermination. So those are the total denials for any reason. Okay? So this information is not cumulative. These are separated out for those purposes. If you look at the very bottom is where you really do get down to the effects of the documentation requirements. And again, as I explained, it could be that the result was they were not able to produce, or it could also be that when they did produce, the result was that the answer should be no, they do not qualify. The one with the square are the redeterminations. You'll notice that both of them did go up. You obviously see at the top there was a spike, but I think what's significant to note is that particularly the second line, which reflects new applicants, reflects the redeterminations, the second line going across, has leveled out. I think that's probably a reasonable expectation. I don't know what will occur as time goes on, but it is significant to note that the past several months it has been at a more level state, as have new applicants. Could be because word's getting out, folks know right up front what documents they need to bring and are able to get them before they come and apply. There could be a number of reasons. It could also be that through the initial phase of doing these determinations, indeed there were a number of folks that should not have qualified, and the result is then that they are being denied. But it's significant to note that it is stabilizing. On the lines at the bottom that have specifically to do with the documentation-related requirements, again, I think you can see there was some spiking upwards, but then both of them do appear to be stabilizing on a month-by-month basis as we go forward. The table or the graph down at the bottom reflects, we thought it would be important to show you the overall effects. And now the family Medicaid is adults and kids all combined. Okay, up at the top it does not separate out children. The graph on the bottom does separate out just children, and it focuses on three categories of children: low income Medicaid, right from the start Medicaid, and Peach Care for Kids. We thought it important or relevant to show the cumulative effect, hence the stacked area graph, showing you that actually there was a bit of a spike last year in the number of folks enrolled, but there is some trending downward. We suspect that you can see towards the end of that line, a couple of months is difficult to absolutely predict, but it does appear as though the decline is stabilizing. The other point that I want to point out, this data here goes through September of 2006. Eligibility data is affected by retrospective eligibility determinations. When someone applies for Medicaid, their date of eligibility will be the date that they applied. So it could be, say for example, I go and apply, I don't have whatever it is that I need, and then I go and get that information and come back, and maybe it took me 45 days to get it and bring it back. Then, presuming I successfully show that I should be eligible for Medicaid, then my eligibility date would go back to that date that I applied. So I think that's important to know as to when we report to you eligibility information. We have a number that we know for January, but we know that number is going to go up typically around 2 to 3% by the time that we get 2 or 3 months down the road because of the retro determinations. The other documents that you have to support what we've done, you've got one that does come from the Code of Federal Regulations. I'm not sure exactly which page that's turned to in the information that you have, but on the third page in the center column, this does address a specific concern that's been raised about children who are born to moms who are either undocumented or have not met the residency requirements to get on, for example, our regular RSM Medicaid. In that case, those moms would be covered by emergency medical assistance, EMA. This directive from the federal government goes on to say that women who give birth to children in that circumstance, their child cannot be deemed eligible like a child who's born on Medicaid. They're deemed eligible for the first year. So we thought that was important for you to have this federal regulation, and certainly at any point in time we'd be happy to discuss that with you further. Another document I want to draw your attention to is, actually it's two documents. One is from CMS, dated July 6th of 2006, and then another one is basically it's a frequently asked questions document. These do give the specific requirements as it relates to citizenship documentation, what's required, what types of documents. Yes, sir.
Representative Higley has a question.
Thank you, Mr. Chairman. I I thank the department for getting this information for us. My concern is, what are we doing to make sure our citizens understand this new requirement is in place? What are we doing at the hospital level to make that new mother understand that she has to get the appropriate documentation so that the child, if eligible, can participate in the program and that kind of thing?
We've done a number of things. We've worked with our Family and Children's Services offices through the Department of Human Resources to make sure they have very clear instruction on how to help folks as they come into the office, what documents they need, what's required. We've done the same with the RSM workers, right from the start workers who are located in hospitals and other non-traditional settings with that same kind of information. And then even more recently, we've begun meeting with, through the Mexican consulate in particular, they've started arranging some meetings for us to go out and have community meetings with some of their constituency, excuse me, so they understand more clearly what it is that is required here in this state to apply for Medicaid. So there's a number of different ways that we're trying to get the word out.
Another question, Mr. Chairman. What are we doing so that in advance, so that the person can go ahead and get all this straightened out before the child is actually born?
We are in the process of working with the DFACS right now to get another round of training done with the DFACS workers to allow, and it was sort of different in different parts of the state. Some parts of the state, they would allow, for example, a potential EMA mom to come in and fill out the paperwork ahead of time, and then when the delivery occurred, then they would simply bring the hospital documents to the DFACS to initiate the EMA, emergency medical assistance. And we're making sure that that's known statewide and made available statewide so folks could come in and do that. Of course, those that are residents and meet the residency requirements or the citizen requirements, we do have the RSM workers that are across the state in a number of different non-traditional kind of places to get in early so they can get prenatal care.
And the last question, Mr. Chairman, if a child in this situation is born with a severe medical condition, what does the hospital do in terms of providing treatment for that particular child, and can they hope to get paid for doing it?
Of course.
The birth certificate gets back 6 weeks later or however long it takes.
Well, actually, we've made it such that the actual birth record from the hospital can be used in lieu of a birth certificate or maybe affirmation on vital statistics, which does take 4 to 6 weeks. So we will accept the actual birth documentation. In other words, let's say that the mom is discharged along with the baby. They are discharged with documents that affirm that the child was indeed born at Hamilton Medical Center in Dalton, Georgia. They can take that directly to the DFACS and go ahead and make the application for Medicaid, for both the EMA for the mom and the delivery, but then also if indeed, obviously the child then does meet citizenship requirements, that document would affirm that. And then presuming that, in fact, the family meets the other requirements, like the income requirements and so forth for Medicaid, then that child could be signed up for Medicaid for a full year at that point in time.
But you still don't answer my question. If the child is born with some type of critical medical condition, what is the hospital to do? Assume that they're not going to get paid, or
no? I'm sorry. They could assist the family in applying for Medicaid right away in the hospital.
So will they get paid from the time of the birth? Is what I'm trying to get to. Okay.
They don't have to wait for the birth certificate. They can use the application to fill out to get a birth certificate. So they don't have to wait for that document to come in order to get Medicaid.
In many cases, the RSM workers are actually in the hospitals and facilitate that even before they're discharged, whether the child has medical conditions or not. It very often is facilitated right there.
Representative Shaw.
Thank you, Mr. Chairman. Y'all help me with this. I've heard all kinds, but it doesn't matter if the mother is illegal or legal. Is the child a citizen of the of USA if they born here in this country. Is that not right?
That is correct.
Okay.
Mr. Trail, will you help me on this chart? The one at the bottom, cumulative child coverage. The numbers on the left-hand side, I mean, is that the total number of, is that the total number of children? In other words, there's a 200-something thousand in peach care and whatever number in right from the start, and so many in low income.
That is correct.
So we are bumping, in some cases, it's right around 1 million total kids.
It's just slightly under 1 million through the data points on this chart.
Okay. Mr. Trail, if you would wind up here in the next couple, 3 minutes, we have this room for another 6 minutes, and I think we have somebody from the composite board here that may briefly address the committee. Before I get there, any members of the committee have any further questions of? I do one question. Ms. Summers, if you would help me on the tracking document where the governor inadvertently left out $9 million. If he had put it in, where would it have gone in this budget document? And can you further direct me to where the executive branch's part of this is located in the budget document?
Mr. Chairman, I think if the money had been added, you would see it as an other fund in our budget under item 17.8.1 on page 5. That $276 million would go up by $9 million. You would want to look in the judicial branch and the legislative branch related agencies and their budgets, and we would have to get the breakout of what that $9 million, how that $9 million will be distributed to those particular agencies. What will happen is they will be assessed a higher percent of payroll, just like every other executive branch agency, and so you would need to give them the state funds combined with whatever other funds may be available unique to that agency to increase the amount of money they have in their personal services budgets in order to be able to pay that additional percent of payroll to the plan.
So it's $9 million for the judicial and legislative, and that got inadvertently left out on page 17.
It is not reflected as revenue to the plan.
Correct. And where it got added as it relates to the executive branch, that's included in the $276 million. Is that correct?
Right. 176 of that 276 is the money made available for the executive branch.
In terms of spread, do you know how much that was? There's $9 million that ain't inadvertently got left out. Do you know how much got put in as it relates to the executive branch?
That's the 176. So if you went to every other executive agency's budget and added up the state funds that were appropriated, just like Department of Community Health, if you look at our budget under the statewide budget changes, like, for example, on item 17.0.3 on page 4, those new state funds, that's, if you'd look at every executive agency's budget and you would see something comparable that would give them state dollars for us to be able to charge the additional percent of payroll, and that would all add up to 176.
So we can find that in another document, wouldn't it? Would be in.
You'd have to look at every other agency's budget to get up to the 176.
Thank you. Any further questions of members of the committee? I know there is someone from the composite board. We're not specifically on the agenda, but you all prepared to address this, if you would.
Do you want to sit up here, or do you want us to put the mic at the podium?
The podium's great.
Okay. Because this is.
Mr. Chairman and members of the committee, I'm Bob Jeffrey, Director of Operations for the Composite State Board of Medical Examiners. Thanks for allowing us to talk with you about this. CSBME, as you know, is the agency that licenses and regulates physicians, PAs, thank you, Margie, perfusionists, respiratory care professionals, and a few other professions as well. In the 2006 legislative session, the General Assembly passed Senate Bill 480, which the governor signed into law effective July 1 of 2006, and that was to grant advanced practice registered nurses the legal ability to write prescriptions under the authority of a written protocol agreement with a delegating physician. That bill provided that we had to promulgate rules and regulations governing these protocols and the delegating physicians, and it required us to review each nurse protocol agreement that had prescriptive authority in it and to determine whether or not that met accepted standards of medical practice, and to require that the non-compliant protocols be amended in order to meet those standards. So, in light of that, the governor has recommended in his 08 budget the addition of one position to handle those processing those reviews, and that comes out to $36,131. And that, I believe, is the only issue on your tracking sheet for us.
And that would be an annualization of your request in 07, is that correct?
Yes, it would.
Any questions from the members? As a matter of information, it's our understanding, actually based on a handout y'all gave us, that you recently revisited those rules and regs. Is that correct?
Yes, we did. We have proposed an amendment to those rules. The notice is in front of you. It's also out on our website, and we have published it as required in I believe, the legal report, daily report.
Could you give us just a quick update on exactly where that is? I mean, these are proposed, and then the board will take.
I'm going to. Absolutely. I'm going to defer that to our medical director, Jim McNatt, Dr. Jim McNatt.
Thank you. There will be a rules hearing, I believe, on March 1st, and then the board will have a conference call on March 9th, which I think is the required 30 days after posting before the board votes on the rules as proposed.
So the board will vote on them in March 9th, is that correct?
I believe that's the correct date.
Representative Stevens has a question.
And I'm still trying to absorb, thank you, Mr. Chairman, trying to absorb some of the rules that are proposed here. Does this fall in line with the intent of the legislation that you know?
We believe that the rules, as amended, closely track the Senate Bill 480.
And there is, I grabbed one of these, there is a website that we can see these rules, correct?
A website that you can access the rules, that's correct. The medical board's website.
Can you give us that website?
I think it's www.medicalboard.georgia.gov. Bob, are you here? I think that's correct.
Thank you.
Is that
Representative Gardner.
As I read these rules in Section D, it still says, and I don't know if this is part of the law or what you put in the rule, but it seems to require a quarterly the agreement shall be evaluated or examined by the delegating physician on at least a quarterly basis. Does that mean the physician has to see the patient on a quarterly basis?
If you're reading the section related to controlled substances, that's in the law. Is that the section?
I guess I probably need to take a little more time and read this. But so
I'll be glad to speak with you outside of the meeting if that would be helpful.
Okay. So only for controlled substances are they required to have this quarterly face-to-face?
That's correct.
And in other instances,
This has been revised so many times, I
You don't
believe
know
it
either.
says
Okay.
yearly.
we will take some time and read these, but thank you.
Sure.
Thank you very much. This concludes our meeting. Again, the meeting tomorrow, public hearing has been postponed. At a future time, we will certainly have one or more public hearings. We also will hear from the Cancer Coalition and their presentation also at a future time. Thank everybody for attending.